So the next section is called Government and a National Public Drug Plan. Our presenter will be addressing how the Alberta government funds affordable prescription medications and why a national public drug plan for everyone would be beneficial to Albertans. Please note, it's a panel of one. Michele Evans, please make your way forward. Thank you. I just want to mention the Minister of Health, Federal Minister of Health, and the Ontario Minister of Health were both invited as well, but were unable to attend. So we are especially grateful to Michele Evans for finding the time to be with us here today. And I'm going to bring Sandra Azokar forward now. I just wanted to remind you that I am from Alberta, and yes, I am wearing the color orange, but I'm also wearing orange and blue because the Oilers made the playoffs. Sandra Azokar has been an advocate for fair and equal society for more than 30 years in the province of Alberta. Her past experience includes working as a child protection worker and volunteer with the Chilean community, as well as in the labor movement. Sandra is here today as the Executive Director of the Friends of Medicare and sat on the board for 6 years prior to becoming the Executive Director in 2012. Sandra.
Thank you so much. It's with great honor that I'm here to introduce our next speaker, Michele Evans. Michele is a pharmacist who has worked for small community pharmacies and large pharmaceutical companies. Michele has been with the government of Alberta for over 10 years in progressive roles, primarily with the Ministry of Health, as well as advancing a number of economic development initiatives. Currently, Michele is accountable for shaping the new divisional priority as the Assistant Deputy Minister for Pharmaceutical and Supplementary Benefits. The division is responsible for pharmaceutical and supplemental benefits, governance, and administration of the Alberta Healthcare Insurance Plan, and provides leadership in blood services, organ and tissue donation policy, and expansion of capacity in acute care services, lab, DI, and cancer. Michele is passionate about the Alberta Public Service and believes strongly in working collaboratively and making connections. Michele has a Master's in Health Science, Health Administration degree from the University of Toronto, and a Bachelor of Pharmacy degree from the University of Saskatchewan. Welcome, Michele.
Okay, so I'm going to try to get us a little bit back on time, so I'll go through some of my slides fairly quickly. So what I'd like to do is talk a little bit about the differences in Alberta's drug coverage relative to some of the ones we've talked about already today. Talk a little bit about what are some of the pressures that we face as we look at government drug plans, where our spending and where our growth is happening. And then talk to a little bit more about where to from here, what's actually happening at with policymakers across the country, and perhaps give you some insight into what my thoughts are around whether or not a national pharmacare program is possible or near on the horizon. So Alberta's drug coverage is fairly complicated. We have about 23 different drug and supplemental benefit plans that we offer to Albertans through 11 different statutes, 12 different regulations, and a number of agreements and different policy pieces. In general, there's 4 types of coverage that we offer. So one is age-based, so we have our coverage for our seniors. We also have an income-based plan for those who are on social assistance or a number of different financial support programs in the province. We have those programs that cover you dependent on your income. We have a plan in Alberta called the non-group plan, and this is a plan that covers all Albertans who wish to join the plan. However, it's premium-based. It's medically underwritten, which means you can have a pre-existing condition, but it's a premium-based plan, and the premiums are $1,500 a year for a family. So again, it's a fairly significant expense to get onto that plan, but anyone could join it if they needed. And then we have disease-specific plans. So we have plans that cover specific indications for cancer, HIV or AIDS, transplants, individuals with high-cost transplant needs. So it is a very complicated and confusing system that has developed over time, and certainly we try to do our best to manage patients and products through a fairly complicated eligibility and program. So these are sort of the commonalities, the differences in who gets what, but in general, sort of the core plans all have the same drug benefit list that they rely on. So there's some consistency. So Alberta has, in general, and this one is just looking at some data on cost per capita expenditures from the government proportion. So Alberta has the second highest per capita government prescription drug expenditure. So we do have a good, relatively generous plan relative to other governments. And certainly we cover a smaller portion of the population. So we spend a lot of money per capita, but we're only covering about 20% of our population. So we cover, through that suite of plans, about 900,000 Albertans out of our 4 million people that are covered. So our plan and our costs are highly influenced by the different plan designs that we have. And just to put it into context, on our core plans, which are our seniors plan and that non-group plan, patients pay 30% of the cost of their prescriptions to a maximum of $25. So for those of you familiar with the Ontario drug plan design, it's more similar to that with a cap of $25 per prescription. So again, when you take a look at all of the provinces across Canada, all provinces now do offer some level of publicly funded drug insurance, but compared to governments again across, Alberta covers a higher share relative to other provinces. So again, higher amount of proportion of government share on total prescription drug costs, but still we see we're only covering that 20% most vulnerable population. The remainder of the drug spend and the drug coverage in our province happens through private employer plans or out-of-pocket costs by Albertans. So I'll skip over this slide. It's a little bit complicated, but again, sort of building on some of the vignettes that Jamie and others have shown, there's significant variability when you take a look at out-of-pocket costs across the country, depending on your plan design. So this just shows examples of out-of-pocket costs for a senior who's earning about $44,000 a year and is on a suite of cardiovascular and hypertension medications. And again, Alberta seniors have a lower out-of-pocket cost relative to every other province other than Ontario. But again, if you look at different population groups, if this was a low-income Albertan who was covered for the same suite of medications on our non-group plan, when you factor in the premiums, their out-of-pocket costs are actually substantially higher. So this just shows a number of different vignettes, and if you're interested, you can go onto the website and see some of those different vignettes that we've done. So when it comes to drug programs, it is important for us to understand the context by which government is making decisions related to funding different parts of the health system. And so this is some slides from our recent budget in Alberta. We're just in the process of passing our budget for next year, and I think it's no surprise to anyone that Alberta is facing a very difficult budget cycle for the province, as the downturn in the economy is quite prominent, and certainly we're struggling with low oil prices. And so some of the conversations that I have within government are very much flavored by what's our revenue situation, where are the available resources in those things coming from. So I think it's important for me to just sort of share with you a little bit of information about where we're at. Alberta, certainly from our province's perspective, generates a substantial amount of our revenues from oil and gas sector. And this has been an unprecedented time in terms of oil prices. So the top right-hand for you guys graph just shows the cycle of oil prices over the last several years. And certainly this has been the most significant drop and the slowest return to recovery that Alberta has ever experienced in terms of oil prices. And our economists are telling us that we do not expect to return to ever to the $100 a barrel heydays of the past, and we're probably not likely to see sort of a $60 a barrel until 2020. So a long, slow recovery is what's being anticipated. So Alberta's financing this by assuming debt, which is a whole other conversation that we can have, while our debt to GDP ratio is still among the lowest in the country, and that's that bottom right-hand graph. Certainly, we're taking that on, and those have significant implications. And I just think that's important to put into context, as many other jurisdictions in this country face substantial debt servicing charges and challenges relative to Alberta. So we're sort of a new entry into this game where we're trying to figure out how do you deal with those kinds of challenges when your revenues and your expenses are out of line. So this government that we're with right now is working to try to reduce and return to balanced budgets in our province by managing operating expenses. And so that's the slide, the graph on the left-hand side. And really what they're trying to do is keep operating expenses to cost plus population growth plus inflation. So that can become very challenging when you're working in the healthcare sector overall. So for us, within our team, pharmaceuticals represent the third largest expenditure on a $21 billion health budget, so about a $2 billion expenditure on pharmaceuticals in our province. And this year, we're fortunate, if estimates passed, we'll get about a 10% increase to the cost of our program. So remember I said overall, expenditures must be managed around that 3% level, and that's the budget increase that Alberta Health has gotten this year, if and when budget passes. But on the drug component, we're growing at 10% per year. So significant pressures within our programs means that other choices have to be made across the healthcare system about what we're not going to fund or where those resources are being reallocated from. And again, I won't spend a lot of time on this slide, but this is just when you look back, we've been very effective at managing our costs over time, but with a number of changes to how we've priced drugs and how much we've paid for drugs and some of the cost containment activities that we've put into play. But over the last several years, or at least in the last recent while, drug expenditures accounted for 25% of the overall increases in the healthcare budget. So it's growing faster than other parts of the healthcare budget. So when things are large numbers and they grow fast, people tend to pay attention to ways that they can slow those sorts of things. So where is this cost pressure and the growth coming from? Well, biologics. So we heard a little bit about biologic medicines. These are important medicines, but they have been, and they make a huge difference for patients and within the healthcare system, so they're important that we do provide good coverage for them. But certainly they're growing between 12 and 17% on an annual basis on our drug plans. And again, our plans do pick up some of those co-insurance patients, so we do pick up some of the patients from the private plans who maybe don't have enough copay or cost coverage, and so certainly an area that we see a significant amount of growth and a lot of pressure in terms of our spend. And certainly we're very interested in new products like biosimilars that offer alternatives at lower cost, where we're trying to manage within those expenditure areas. Another thing that hit our programs quite significantly over the last 2 years was the introduction of the hepatitis C drugs. So in 2015-16, we spent over $66 million in Alberta alone on hepatitis C treatments for just under 1,000 patients. Again, last year we expected to spend a similar amount, and the numbers are just finally coming in for the year. And next year, because we've opened up access to less severe patients, certainly we expect to see this number nearly double. So a significant amount of cost, significant amount of benefit. These are some of the most cost-effective treatments that we have, but it certainly comes at a price. The other thing we see within our drug programs is changes in who's eligible and how many people we have coming on. So one of our biggest points that drives our costs is the increased number of seniors. So Alberta has generally a young population, and we see about 60 new seniors join our plans every day, so about a 4% growth since 2013. So again, more seniors using more drugs, starting to pay attention to where are those things coming from. But it's not just seniors, and certainly what we have seen is with the downturn in economy, a number of increases in our low-income plans, which actually mirrors the unemployment rate for our province. So Alberta's unemployment rate typically sits around 4%. Over the last 2 years, we've seen that unemployment rate rise to a high of 9% over time, and certainly that has been reflected in our low-income plans. So again, just unexpected or unanticipated or pressures from the who's involved and who's using your drug programs. So where to from here? So as a government, what we think about and what we talk about are sort of 3 pillars of action that we can undertake. So we talk about evidence-based appropriate use strategies, trying to figure out how we can get better use out of the products that we are already covering for maybe a lower cost, or get more value out of the products that we're using. So substituting lower cost products, and I won't go into some of the programs, but we've got products where we'll use a lower cost proton pump inhibitor and only pay up to a certain amount. We've got substitution happening in one of our other high expensive areas where we're substituting Avastin for Lucentis. And these have resulted in some important changes in terms of our expenditures overall and created some room for us to fund some of these new therapies. Certainly, we've been working very closely with our colleagues across the country around pricing and purchasing. And so trying to get better prices for our drugs. And we're in an unprecedented era of collaboration, and I'll talk a little bit more about some of the work we're doing just at a high level on pricing and purchasing. And then we talk about our long-term approaches. How do we take a look at that complex drug plan design that we have, where we have so many different plans and it's hard to navigate? And then what are we doing about our pharmacy business? Have we negotiated the best rates with our pharmacists? And are we paying a reasonable rate for the services that they're providing and getting good value for that? So Alberta has the most comprehensive scope of practice for pharmacists. We not only pay the dispensing fees and markups, we also pay for care plans and smoking cessation. So we compensate our pharmacists far better than any other part of the country and perhaps in the world. So are we getting good value for those dollars that we're spending there, or could we do it differently? So just to give you some insight into the Pan-Canadian Pharmaceutical Alliance. So for those of you who don't know, this is an affiliation of all of the 13 provinces and territories, as well as the federal drug plans. We are all working together to get better value for our brand name and generic pharmaceuticals. And there's been some important successes in this work. So this data is current as of last year. We had completed 95 negotiations, reduced prices on the 18 most popular, most highly used generic drugs, and we collectively realized about $712 million in savings. We don't have the final number calculated now, but I can tell you that as of the end of February, we had completed 142 negotiations, of which 10 resulted in no agreement. So we actually shut down and said, no, we're not able to reach an agreement with these manufacturers. So I'll move past that. Long-term plan design. So again, I highlighted that we have a lot of different plans in Alberta. And while they're effective at targeting the variety of individuals who have those needs, we still know that there are gaps within our system. So they're faced with sort of 2 main challenges. There is a portion of our population who choose to or are unable to afford a plan. While we have that non-group plan where everyone can join the plan, unless your drug costs exceed $1,500 a year, it's unlikely that you will take that plan out. So we see some Albertans struggling with the cost of their drugs simply because they won't join the government plans that are available to them. So they don't have that safety net. We also see, as I sort of talked about, that continual rise in drug program costs, and trying to understand, is this the place? How do we deal with the new drug prices, the new expensive medications, the new treatments that are coming on? How do we make those decisions and contain some of that growth so that we don't eat up the rest of the health ministry's lunch? So when we talk about plan design, we talk about who should be covered and what should be covered. So, we can take a look at a universal plan design where we continue to cover everyone first dollar, or we could have more of a continued effort around customization and focusing on the most vulnerable or only those who have high medical needs. So we haven't landed on all these sorts of things, but these are the kinds of policy conversations that the work of many of the people around the room here, the researchers, it's very valuable for us to inform these kinds of conversations. We also talk about what's covered in terms of the list. Do we need to cover all medicines that are available, or can we narrow the list, and what are the implications of only covering a certain set of essential medicines or a smaller list of drugs than we currently do cover today? And then we talk about how should they be covered, and should we have sort of restricted public funding where we have a fixed budget and we set and limit the growth to sort of a specific amount, and put some greater controls on our budgets and and constrain our public funding, and say after a certain amount there's put some sort of better controls than we have today. Or we could look at more extensive public funding and opening it up to first dollar coverage and trying to be more inclusive around those plan designs. So these are very early days, and we've been having these conversations. I certainly can say that it's not necessarily a platform of our current government, to address drug plans, but certainly they're very interested in understanding the cost pressures around who's covered and who's not covered. But when we sort of speak about, are we ready for a national drug plan? It's not something that we have been talking about collectively as jurisdictions, and certainly not something that I think our government has necessarily got in their existing platform and are ready to take action on. So events like this, conversations like you have, are important because they help shape sort of future platforms and future work that can happen. Pharmacare, certainly has been stated today as sort of that unfinished business of Medicare. And while we've had substantial collaboration through the FPT efforts around PCPA, we are still not talking about a national pharmacare plan at those tables. We're focused around sort of what we call the 3 A's. So we talk about appropriateness, we talk about accessibility, and we talk about affordability. And so there's a number of activities and work that we're doing in that regard, but certainly we're not looking at how do we align all of our government-sponsored drug plans across the country at this point. And so again, I think it's important that people understand that this is a difficult road to move from where we are today with the challenges in our drug programs to where we might be in the future. And certainly, again, just wanted to share that I think it's a great idea. It's certainly hard to implement from the perspective we have, and certainly having political support and other support from the public makes our jobs that much easier as we work through some of the challenges we have in terms of managing a very complex system and trying to just keep the lights on every day when we come to work. So with that, I'll conclude my remarks and open it up for questions.
For being under time.
I didn't want to keep people between their drinks.
We'll start with mic 2, mic 1, mic 2. We'll go back and forth. How's that? Fair? All the men are at one and all the ladies are at the other. Interesting. Mic 2 first.
Hi, Tom Perry, UBC Therapeutics Initiative. I appreciate your presentation. I'd like to be asking this to your health minister or premier, since I'm still an NDP member and a former MLA in BC and cabinet minister, but perhaps you can take this message back. One of the most disappointing things to me is to think that an NDP government in a tremendously challenged province like Alberta now would not be taking more visible leadership on this. And the one where I think there's an intersection with what you might be allowed to say and what I hope you'll take back is to challenge the notion that more drugs and more spending is automatically good. I think we've heard already this afternoon more spending is not necessary to do a much better job nationally, but there's been an implicit message underlying everything that more spending is good, kind of in the same way that more military spending is good, it will make us more secure. And it may not be quite an opposite metaphor, but one of the problems is that any better doctor, non-conflicted doctor in Canada would almost certainly agree we don't know how to treat most conditions optimally. And diabetes is probably the biggest and best example because it affects so many people. We have no idea how to treat type 2 diabetes. And we will never know because the existing paradigm is that we're not entitled to know. Pharmaceutical companies almost exclusively fund the research. It's opposite to their interest to find out the truth. And the only possible way to make that better is government funding. We have a large enough population in Canada to relatively easily learn the answers to those questions if we did the research, but no Canadian government has ever proposed that. We came close in BC. We almost got in 2004 to an experiment with Alzheimer drugs to find out if they're any good or not, and secondarily, if they were any good, whether one was better than others. That was sabotaged by the industry and by medical leadership. I was in the room when that happened, and the industry sabotaged it right under the nose of the senior bureaucrat. So I'm hoping partly you'll take a message back to your politicians, but also wondering if there's anything you can say about that, that we might see government leadership towards rational drug policy other than exclusively coming from the public.
So maybe to just comment on that, because certainly I can't comment on the political leadership component of it, but I do think that political leadership will be an important component of advancing a pharmacare program. As I mentioned, and from a policy perspective, what I have to do is try to provide a balanced perspective on sort of here's the pros, here's the cons, here's the implications of who benefits and who doesn't benefit. And so that political leadership is, I think, critical to success of any pharmacare campaign.
Mike 1.
Hi, Sandra from Friends of Medicare. I just have a question, I don't want to put words in your mouth, but what I get from you is that the federal government at this point is not looking at a national drug plan. And they're saying that they're not ready. So in a lot of ways, we've heard what the BC and Quebec experience has been. Do you see a role for provincial governments to become leaders in implementing their own pharmacare program within their provinces, or is that something that that would kind of defeat the purpose of a national pharmacare program? How would you see those two things either coexisting or not existing at all?
So thanks, Sandra. I think, so I was involved in the National Pharmaceutical Strategy in around 2006 when that came into play. And one of the things that I will always recall is the quickness of federal-provincial relations and how it turns to conversations about finances. And so for me, I think success in the future keeps some of those conversations away from those tables. I think that we don't have a single unified Medicare system. I think we all believe that we do, but if you looked at what a physician gets compensated for in Alberta versus Ontario versus Nova Scotia, it isn't exactly the same. So we have systems that work to make reciprocal billing work and make those systems a single unified system, and that's certainly an excellent role for the federal government. I think, though, you will need to see a single province or a group of provinces take leadership on this file, since sort of the responsibility and the jurisdiction for delivery of those health services is something that resides in those provinces. So I don't think there's no role for the federal government, but I think that having a focused role for how they can help contribute and bring others along will be something that makes it go forward.
Mike 2.
Hi, it's Bill Swan from Nova Scotia. I'm trying to put together the website Faces of Pharmacare. collecting stories for an opposite narrative. Just 2 points. One, about every month I call Rachel's husband, Lou, and I give him an earful. He hasn't listened yet, but I keep calling. The second is to do with the Pan-Canadian Drug Alliance. I keep seeing this number, 712. A couple of years ago, it was 460. Why can't I find how that number is arrived at? I'm sorry to be a skeptic, but show me how it's done.
Yeah, and so those are confidential pricing agreements that we reach, and so how those are done are based on the forecasts and the calculations of our expenditures, but I will certainly take it back, and perhaps we can provide more clarity on the method by which we calculate that, and so it's a collective number based on the rebates that we get.
Thank you.
Mic 1, and only the people at the mics currently will be accepting questions from, and if you could cut right to the question, that'd be awesome. Mic 1.
I think in the pursuit of finding where to live, perhaps as a millennial, again in the room, you might want to look at the healthcare provisions and the healthcare responsibilities that you have as a co-payer, as a payer, as your employer. So these are just, again, some of the complexities around people searching for jobs today, paying the bills, paying childcare, getting married, having the responsibility, owning a home, all of these things. So maybe, in fact, with Alberta having an increased line of unemployment and then those numbers propping up, you'll get the clearer picture of what's happening across the province, because that hasn't been the case for quite some time. And good luck to you as you renegotiate some of those opportunities for unemployed. The other is, importantly, I think, as we go up against pricing constraints and what that gives us to navigate, what are you finding when you try to promote generic quality versus name brand in your line of negotiations? Because in Ontario currently, with the trade agreements that are coming forward and protecting brand names, I think that's going to be a lot of the conversations that we're going to have with MPs, that their kind of hands are tied. Right now in my community, we have promotions with school boards, and this, I'm not going to name who, but they are bringing in with our young children today, and they're branding their packaging of pharmaceutical, and they're sponsoring children's events, and they're promoting name brand drugs at their events, as opposed to or saying generic drugs are 60% not good. So they're out there already with our young children talking brand.
Yeah, so I think that's, I'll just pick up on that last piece around about brand and generic use. And certainly, historically, the mandatory use in public plans has made a difference and helped people use more generics, but I think that is changing. The industry has gone through a period where they've had a lot of loss of patents and certainly more challenged by the number of generic competitors. And so we're seeing shifts and different practices by the brand industry to try to do that. And so coupon cards, all sorts of promotion and other activities, no substitution pads for physicians. So there's a huge challenge there. And I think our tools are being challenged. Our historical tools that we use to encourage generic use has been challenged. That's not to say our generic prices are all that great, and I know that we have a ton of more work to do on the generic pricing when you look at Canadian prices relative to others. So not only increasing the use of generics and making sure we're paying attention to that, but also trying to continue to decrease the prices that we're paying there. So yeah, it's not easy.
Thank you. Mike 2.
Yeah, so there's lots of issues that come up in your presentation, which I don't fault you for. I think, you're trying to look at Alberta and reducing costs, but as a whole, the only way to do this is if there is work together across in a pan-Canadian way. As we all applauded the Pan-Canadian Pricing Alliance, Pharmaceutical Alliance for lowering costs, it actually is leading us in the wrong direction in many ways. If you look at generics, you point out that Canada has the highest generic costs in the world, but it's a schedule and it's going to be anti-competitive. We're going to see that PCPA lead to is fewer generics come on because they don't want to drop the price. So that is a poison pill that's right in the system, and you have to deal with it. The other is that the federal government has invited, the minister is inviting the private sector into the PCPA to benefit from the lower prices. It's the one stick that we have to sort of figure out how to get money out of the private sector. Instead, we're inviting them to the table at no cost. That is hugely problematic, and I think that the provinces should be stepping up and saying, draw a red line in terms of that doesn't lead us to pharmacare. We're actually headed further away, even as we're saving some money. And, you know, great that collectively we're now negotiating lower costs, but there are problems in the PCPA. It was put together because Harper wasn't at the table. There was no national consensus on and no leadership. Now, in a way, it's become a problem, and I know that, you know, we have to figure out how to deal with this. So.
Yeah, no, and certainly just to respond to that, absolutely, product listing agreements and rebates, confidential rebates, are a very sharp knife that we walk on every day, and it is certainly something we would prefer to see visual, like actual lower prices in the country. It's not the world we work in right now, so absolutely agree that this is a really challenging area for all of us, and how we come to these kinds of agreements, not being able to talk to them, and then being held to public transparency and accountability. It is a very, very sharp knife to walk, for sure.
And CETA as well. So we're going to get compensation. The feds are going to compensate the provinces for these increased drug costs, but we're headed again in the wrong direction there.
Yeah.
So.
I'm going to take the gentleman at mic 2. He was there before you, and then Marc-Andre, you'll be the winder-upper. Mic 2.
Thank you for the presentation. It's really interesting to hear what's happening. In BC, there's a program of reference-based pricing, so the lower cost drug is covered and then people have to pay for the higher. Have you used that at all in Alberta?
So Alberta introduced the very first category of what we would call reference-based pricing. Obviously, we didn't use that language. We used maximum allowable cost. So we did our first category in September and gave a sort of a 4-month transition. So that's the first time we've done that.
And the second part of that is in BC, there's been a fair bit of opposition from physicians. How has it worked out in your relation with physicians and the pharmacy program?
So at this point, because there's been a lot of opposition through BC, and the category we did was proton pump inhibitors. It's a stomach medicine, and there's a substantial amount of evidence to support that they're all reasonably similar. We did not get a lot of pushback at this point, but you know, sort of long lead times, learning from some of the other lessons, and very different plan design than other provinces, right? So because the impact to patients is a little bit different than it is in BC and others.
Thank you.
Thank you, Marc-Andre. Pressure, pressure.
Standing between you and drinks. So
And dinner.
And dinner, yeah.
Michele, first, thank you very much for this presentation. I mean, it's great for you coming here. Two things I want to mention. A very quick thing about more works need to be done with generics. In Quebec, basically, we're removing the caps on the rebates pharmacies can receive on generics. And pharmacists started receiving a list of potential rebates they could get if they decide to go with this company or this distributor. And in Quebec, well, the price of generics, most of them, it's 25% of the price of brand name drug, but at the same time, many of the drugs are 18% of the price of the brand name drugs. But the rebates offered on average was an additional 70% under that. And so going for some drugs from 18 to 15% is just, there's still a long way to go in terms of the money that is still on the table. So I just wanted to mention that. But still, it's great to see the PCPA trying to do some good work in spite of the different difficult context sometimes. You mentioned Hep C and Sovaldi, Harmony, and Alkirapac being one of the driver of the increase in the cost of drugs, because there was a question about access to treatments. In all provinces in Canada, basically, for these drugs, the price is so expensive that we cannot afford the drug for everybody with the disease. But it's an infectious disease, so we always keep a pool of infected patients, basically reproducing the disease, reproducing the market. And I think drug companies understand that very well. So it's one of the reasons to keep a very high price on this. So yes, huge driver in terms of cost increase, but we're only treating the most severely ill patients, and we're telling the other, well, you're still not sick enough. Let's come back in 1 or 2 years, and then we'll see if we'll treat you. There's one province, in fact, that did something different. So instead of covering all the new drugs, so PI is absolutely not a good model for pharmacare. I want to say that. So it's mostly disease-specific programs. But when it came to Hep C, they did something very interesting. They told us, they said, well, there's 3 different companies. So I think Bristol Myers Squibb, Gilead Science, and AbbVie that has this new generation of cure for Hep C. So let's negotiate with these companies. And, well, AbbVie with Alcurapac decided, okay, we'll give you the drug, but instead of $72,000 per treatment for 12 weeks treatment, we're offering it to you, so I don't know the exact price, but let's say under $20,000 per treatment. But the thing is, then PI said, okay, well, we'll get only Alcurapac at this lower price. We'll treat everyone with Hep C on the island. So it's 400 people on the island, so it's a 3-year program, $5 million for that. But the impact on the cost increase for PI with this new generation of drugs for Hep C is not higher than other provinces, but the main difference is other provinces would only be treating the most severe cases, and PI is treating everyone with Hep C without an additional cost impact. So is this something conceivable in other provinces?
Yeah, so as of April of this year, PCPA, well, I should say, as of February this year, PCPA negotiated a new series of Hep C arrangements that will see it expanded to substantially more individuals who are less compromised and have a lower disease status. So eventually, once this is all done, it'll be F0. And so that was done collectively. And so the provinces are now implementing those agreements. And so we implemented that as of April 1st. BC and Ontario have implemented the first round of that. I think it was a month before us, so probably March. And so yes, that is exactly what we were able to do through the collective power of everyone, was to get a much better price to treat more patients and eventually treat all of the patients within the capacity of our systems.
Okay. Okay, thank you very much, Michele. I was joking. I was joking earlier, we had to come all the way to Ottawa to meet. We live in the same province. So thank you very much. My pleasure. Thank you so much. Thanks for doing the photo op here quick. All right, so we realize we're standing between you and supper. Just a couple of quick announcements. If you want to continue the conversation and networking, please join us at 7:30 p.m. to 9:30 here in the hotel in the Panorama Room. It's at the very top, and it's absolutely stunning view up there. And in case you are undecided about coming, it will be an open bar this evening. You're welcome. One more thank you to all of the presenters today. Thank you to all the presenters today for their time and talent that they put into creating what we learned and listened to today. And thank you to you, the audience, for your rapt attention and knowledgeable questions.
And just a reminder, presenters and CHC to the front of the room.
Oh, can we have the presenters from today and the CHC board to the front for a photo op right now? And tomorrow morning at 9 a.m., we'll be starting all over again. So board and presenters to the front, please. Thank you.